Hello everyone, this is Dr. Vaibhav and today we are going to discuss science related to chest masses. So we are also going to discuss how to identify lung masses from mediastinal masses and various mediastinal masses from one another. This will be like a very short session. After this session, we'll also have a dedicated session just to distinguish anteromediastinal mass from middle and from middle mediastinal mass and posterior mediastinal masses. Okay. So without delaying any further, I think we should start the session. So the first thing is mediastinum. So how mediastinum is divided? So this question has been asked in the examination many times, and people fail to mention where is the anterior mediastinum, where is the middle mediastinum, and where is the posterior mediastinum. One more thing I have seen that people also mention superior mediastinum as a part of mediastinal compartment. So as soon as you enter in the radiology, I know in the MBBS days we used to divide the mediastinum into 4 compartments: superior, anterior, middle, and posterior. But as soon as you enter into radiology, there is no more superior compartment. There are only 3 compartments, and according to the Felsen classification, which is widely accepted, there are only 3 compartments: anterior, middle, and posterior. You should also be knowing how to identify anteromediastinal masses from middle and from the posterior mediastinal masses. For that reason, you need to know what are the boundaries of mediastinum. So this is the anterior mediastinal mass. Okay, anterior mediastinal region. In anterior mediastinum, heart is also included. So it starts from posterior aspect of the sternum, and posteriorly it ends along the anterior aspect of the trachea and posterior aspect of the heart. Sometimes people confuse posterior wall of trachea as well in the anterior mediastinum. Okay, so the middle mediastinum starts from the posterior boundary of anterior mediastinum, which is anterior wall of the trachea and posterior wall of the heart, and ends 1 centimeter just posterior to the vertebral bodies. Okay, and posterior mediastinum starts from 1 centimeter. If you draw vertical line 1 centimeter behind the anterior margins of vertebral bodies, then this is the posterior mediastinum. And this Felsen classification is based on the lateral radiograph. Now, what are the main structures in anterior mediastinum, middle mediastinum, and posterior mediastinum? The main structures you need to know, because then you will be able to tell the differential diagnosis based upon where is the lesion located. Okay, so for that reason, we need to know what are the main structures in anterior, middle, and posterior mediastinum. In anterior mediastinum, there are main structures such as fat, lymph nodes, thymus, heart, and ascending aorta. Okay. In middle mediastinum contains trachea, bronchi, lymph nodes, esophagus, as well as descending aorta. Posterior mediastinum is basically predominantly made up of bones and paravertebral soft tissue. If any lesion is arising from vertebral body, then that is in the posterior mediastinum. Now coming to the approach, how to classify chest masses. So first you need to know whether the mass is situated in the lung or whether it is situated in the mediastinum. We'll see how to identify lung masses from the mediastinal masses. And the next step in the approach is, if it is in the mediastinum, then which compartment of mediastinum? Is it in the anterior mediastinum? Is it in the middle mediastinum? Or is it in the posterior mediastinum? Then the last thing is, what are the differential diagnosis? So differential diagnosis we need to mention based upon the morphology and age of the patients. Okay. Now, how to distinguish lung mass from the mediastinal mass? This is very simple. We have been studying this from day 1 of our radiology residency. So if the mass is forming acute angle with the lung, then this is lung mass. If it is forming obtuse angle with the lung, then it is a mediastinal mass. Okay. If it is broad based towards the mediastinum, then predominantly it is a mediastinal origin. If it is not broad based, it is a narrow based towards the mediastinum, then it is lung in origin. If you see air bronchogram within the mass, then that is predominantly a lung origin mass. If there is no air bronchogram, then you can say that this might be arising from mediastinum, if it follows previously to describe features. Okay. Then mediastinal masses are majority seen on both the sides. Lung masses are usually on one side, and the mediastinal masses will cause disruption of the mediastinal lines. So what are the mediastinal line? The anterior junction line, posterior junction line, azygoesophageal recess. So if you have any disruption of those lines, then it will be of mediastinal origin. The lung masses are usually surrounded by air, so the mediastinal lines will not be disrupted in lung masses. So coming to the anterior mediastinal masses sign. So if there is a mass in the mediastinum and you think that is in the anterior mediastinum, then there are few signs that you need to know that will help you in order to distinguish and confirm that this is an anterior mediastinal mass and not situated in the middle or posterior mediastinum. Okay. So the first line is displaced anterior junction line. So this is how the anterior junction line will look like. Okay. So this is the anterior junction line. It is formed by 4 layers of pleura. Okay, 2 parietal pleuras and 2 visceral pleuras. And if it comes together, then it forms a distinct line, that is a anterior junction line. If the anterior junction line is displaced either to the right side or to the left side, or if you are not able to identify anterior junction line, then there is something situated in the anterior mediastinum, and then you can classify the masses in the anterior mediastinum and not in the middle or posterior mediastinum. So on the chest x-ray, on the frontal projection, you need to see this anterior junction line over here. If it is disrupted, then you can think of anterior mediastinal mass. Then the next sign which is going to help you in order to confirm anterior mediastinal mass or not is obliterated cardiophrenic angle. So this is right cardiophrenic angle, this is left cardiophrenic angle. If there is any mass situated and it is causing obliteration of this right or left cardiophrenic angle, then you can safely say that the mass is situated in the anterior mediastinum and not in the middle or posterior mediastinum. Then the next sign is obliterated retrosternal space. As we have seen, according to the Felsen classification of mediastinal compartments, the retrosternal space and heart, it comes into the anterior mediastinum. And the retrosternal space, because of the predominant lung tissue situated over there, that is the reason you see this clear space, this translucent space in the retrosternal area. And if the translucent space or clear space is not seen, then you can think of anterior mediastinal mass. Like in this case, this is a normal patient and this is a patient with anterior mediastinal mass. Ideally, in normal patients, you need to see this retrosternal clear space, translucent space. If the retrosternal clear space or translucent space is not seen, then you can think of anterior mediastinal mass. Okay. Then comes the sign which is known as hilum overlay sign. So what is hilum overlay sign? If there is a mass at the region of hilum, if there is a mediastinal mass, okay, and then if you are able to see pulmonary artery through it, okay, then the mass is either situated into anterior mediastinum or posterior mediastinum. And then if you get a lateral X-ray chest done and if you see retrosternal clear space obliteration, then you can think of and you can label this as anterior mediastinal mass. And this is the CT scan of the same patient. You can see this is a thymic cyst. Okay. So hilum overlay sign tells you that if the pulmonary arteries are well seen through the opacity, that means the lesion, the mass is either situated into anterior or posterior mediastinum. In order to further differentiate whether it is situated into anterior or posterior mediastinum, you have to get a lateral chest X-ray done. And if on the lateral chest X-ray there is a obliteration of retrosternal clear space, then you can raise a possibility of anterior mediastinal mass. Okay. And the last one is effacement or increased density of the ascending aorta shadow. So this is how the ascending aorta goes, right? This is the expected location of expected course of ascending aorta, arch of aorta, and then the descending aorta. Okay. If you see there is effacement or increased density at the location of ascending aorta, then you can think of anterior mediastinal mass, because ascending aorta is a part of anterior compartment, anterior mediastinum compartment. Okay. This is the CT scan of same patient, which is showing heterogeneous enhancing lesion, most likely of thymic origin. Okay. Coming to middle mediastinal masses. So there are some signs which will help you to confirm that this particular mass is arising from the middle mediastinum and not from the anterior or posterior mediastinum. The first sign is widened paratracheal stripes. Okay. So predominantly the right paratracheal stripe is very well visualized as compared to the left paratracheal stripe. and the thickness of the right paratracheal stripe should be less than 5 millimeter. If it is more than 5, if it is 5 millimeter or more than 5 millimeter, then you can think of some pathology which is situated at right paratracheal location, most likely an enlarged lymph node. Okay, and this right paratracheal stripe is formed by the right lower border of the trachea, then associated connective tissue, and then the pleural surfaces. Okay, all these structures together form right paratracheal stripe, and the thickness of paratracheal stripe should be less than 5 millimeter. If it is 5 millimeter or more than 5 millimeter, then you can think of there is some right paratracheal pathology, like in this case. This is a normal case. Here you can see there is a whitening of the right paratracheal stripe. There is also some indentation on the right lower border of the trachea and associated superolateral aspect of the right menstruum bronchus. And this is a CT scan of same patient, which shows a hypoenhancing structure at the level of right lower paratracheal location, most likely an enlarged lymph node. Coming to the next sign, which is displaced azygoesophageal recess. So this is how the azygoesophageal recess will look like. First, we will study what are the boundaries of azygoesophageal recess. Then we'll see the course of azygoesophageal recess. And if there is any disruption of the azygoesophageal recess or displacement, then you can think of middle mediastinal masses. Okay. So on the right side, it is formed by the pleural surface of the adjacent lung. Pleural surface that includes parietal pleura as well as visceral pleura. On the anterior side, there is esophagus. On the posterior side, there is azygous vein. Okay. So these are the boundaries of azygoesophageal recess. Now we'll see the course. So on the in upper 1/3 location, it is seen extending superolaterally on the right side like this. Okay, it goes superolaterally on the right side because of the course of azygous vein. Azygous vein goes like this on the right side. In the middle 1/3 and lower 1/3 location, it is predominantly straight because of the straight course of the esophagus. So if you see any displacement of the azygoesophageal recess or any disruption, then you can think of middle mediastinal mass. Okay. Now coming to the posterior mediastinal mass signs. So there are few signs which will help you to localize particular mediastinal mass into posterior mediastinum, and these signs are paraspinal line sign. Okay. So this is the paraspinal line. It is better seen on the left side and not on the right side because of the presence of the descending thoracic aorta, which uplifts the adjacent pleura, and that is the reason this left paraspinal line is very well visualized. Okay, and if there is any mass, and this is the right paraspinal line over here, and if there is a mass and there is obliteration, displacement or disruption of the paraspinal line, then you can think of posterior mediastinal mass. Okay, the next sign which will help you is erosions of ribs or vertebral abnormalities. If there is erosions of ribs or vertebral abnormalities, such as in cases of nerve sheath tumors or neuroblastoma, that will help you to distinguish and to localize the mediastinal mass into posterior mediastinum. How? Because these are the aggressive lesions, and only the lesions situated in the posterior mediastinum will cause erosions of the bones. Okay, and widening of the bones. So this is a case of neuroblastoma. Here you can see erosions of the posterior aspect of left upper thoracic ribs. And if there is a case of nerve sheath tumor or schwannoma or ganglioneuroma, ganglioneuroblastoma, you can see widening of neural foramen or some vertebral abnormalities over here. Also in cases of neuroenteric cyst. Now, these signs, if you remember these signs, and these are the major signs. I have not gone into some minor signs. There are many more minor signs, but those minor signs will not help you practically in order to localize any mediastinal mass into particular mediastinal compartment. So these are the major signs which you should know of, and that will help you in your final exam in order to localize any particular mediastinal mass in mediastinal compartment. Okay. Now we'll see some dedicated signs which will help you, which are important as far as categorization of mediastinal masses are concerned into various compartments. So first is Silhouette sign. This we have discussed in the previous lectures as well. So what is Silhouette sign? So first you need to understand that if there is density in the tissue difference, if two tissues are situated close to each other and there is a difference in density, then you will be able to outline the boundaries of those particular tissues. Okay, this is the basic concept behind this silhouette sign. Okay, so if two structures are in close contact with each other, and if you are able to identify the boundaries of two structures separately, then the densities of these two tissues are different. Okay, understood? If the densities of two tissues are same and they are in close contact with each other, then you will not be able to identify the boundaries, the overlapping boundaries of the two different tissues which are in close contact with each other. Okay, so there are only four densities as far as radiographic densities are concerned. So these four densities are air, fat, water or soft tissue, and last is bone or calcium. Okay, if this you need to understand and you need to know these four densities. There is one more density which is metal, but metal is predominantly a foreign body in cases of human body. So these four densities you should know of, and if two structures of similar density are in close contact with each other, then you will not be able to identify the boundaries of these two structures separately. Okay, so what silhouette sign says? Silhouette sign says that there will be non-visualization of border of an anatomical structure that is normally visualized due to the area neighboring this margin is filled with the tissue or material of the same density. Okay, so this is the silhouette sign. So this is how the silhouette sign will look like. So this is a mass. Okay, and this is the right heart border. Okay, so here, since the density of two tissues are same, that is the reason you are not able to identify the medial border of this mass and the right heart border separately. Okay, and if the structures are overlapping but the borders are seen separately, then there is a density difference between two tissues. Okay, so this is the caveat of silhouette sign. Okay, so silhouette sign says if the two structures are in close contact to each other and they have similar density, then you will not be able to demarcate the overlapping margins of these two structures, and basically there is loss of silhouette. And then you can say that the since the margins are not very well visualized of the right side right heart border, that is the reason this mass is situated in the anterior mediastinum. Okay, this is the normal chest X-ray. Now coming to the cervicothoracic sign. So there are two parts to it. Cervicothoracic sign, we'll discuss this first part. Then we'll go to the second part of cervicothoracic sign. So where cervicothoracic sign is most commonly used, it is most commonly used when the lesions are located at thoracic inlet. Okay, you need to identify and categorize these lesions, whether these lesions are situated into anterior mediastinum or posterior mediastinum. Okay, the idea behind this is that the anterior mediastinum ends at lower border of the clavicle. Okay, if you can still see the mass is going up to the medial border of both the clavicles, then the mass is situated in the posterior mediastinum. Okay, the posterior structures extend higher, the anterior structure is limited by medial ends of both the clavicles. So when do you call cervicothoracic sign positive? So if the mass is visible above the clavicles, then it is most likely posterior mediastinal lesion. Okay, like we discussed, like in this case, see the mass is going up and it is very well visualized. The superolateral border is very well visualized. So this is a posterior mediastinal mass. And if the upper border disappears at the level of clavicle, then this is anterior mediastinal mass. Like in this case, the upper border of the mass is not seen extending above the medial end of clavicle, then that is the reason this mass is situated in the anterior mediastinum. One more sign that is helping you in characterization and localization of the mass is that this is causing silhouetting of the left heart border. Okay, that is the reason it is situated in the anterior mediastinum. Okay, now this is one part of cervicothoracic sign. The other part is this. Okay, so you need to see the superolateral aspect of the mass. Okay, so if the superolateral aspect of the mass is very well visualized, then the lesion is situated in the posterior mediastinum. Okay, sorry, And if the superolateral aspect of the mass is not very well visualized, then the lesion is situated in the anterior mediastinum. Why is it important? Because sometimes the x-rays taken are not ideal. Okay, and sometimes you get such kind of x-rays and you feel, and it looks like the lesion is extending superiorly, right? But since the superolateral border over here, it is not very well visualized. That is the reason this mass is situated in the anterior mediastinum. Had the superolateral margin of the border is well visualized, then we would have called this lesion into posterior mediastinum. Okay, because many a times in practical radiology, in actual practice, you get such cases where, like these cases, where it looks like the mass is extending upwards to the medial end of the clavicle, but since the border superolateral aspect of the mass is not very well seen, like in this case, that is the reason we are not calling this lesion into posterior mediastinum, we are calling this lesion into anterior mediastinum only. So this is how the anterior and posterior mediastinal masses are localized based on cervicothoracic sign. Now coming to thoracoabdominal sign. So thoracoabdominal sign will also have two components. We'll discuss the first component and then we'll go to the second component. Okay. So when is thoracoabdominal sign is used? So basically it is used when you have a mediastinal masses situated in the lower portion of the chest. Okay. And then you need to identify whether it is situated into anterior mediastinum or posterior mediastinum. The idea behind that is, anterior in the anterior mediastinum, the diaphragm is at this level. So the diaphragm ends at this level, at the lower border of the heart. Okay. And in posterior mediastinum, since posteriorly the posterior costophrenic angle is lower down as compared to the anterior costophrenic angle, that is the reason you can still see the posterior aspect. Even below the diaphragm, you can see the border very well. Okay, this is how you are going to identify whether the lesion is situated into anterior mediastinum or posterior mediastinum. Okay, so the posterior mediastinum continues below the diaphragm into the abdomen. So posterior masses can be seen extending inferiorly, like in this case. So this is a posterior mediastinal mass, and the posterior, the border is still seen extending inferiorly below the right dome of diaphragm. That means the lesion is situated in the posterior mediastinum. The anterior mediastinum is limited by the diaphragm, so anterior masses become obscured at the level of diaphragm. Okay, so this is the anterior mediastinal mass because it is ending and the border is not clearly visualized below the right dome of diaphragm. So this is the anterior mediastinal mass and this is the posterior mediastinal mass. This is the one part of thoracoabdominal sign. The other part of thoracoabdominal sign, you will have to guess whether the epicenter, the predominant epicenter of the mass is in the chest or is in the abdomen. Okay, so the thoracoabdominal sign will help you in order to distinguish whether it is a posterior mediastinal mass or it is a posterior mediastinal mass extending into abdomen, or whether it is a abdominal mass extending into the chest. Okay, extending into the posterior mediastinum. Okay, so how can you tell that this is an abdominal mass extending into chest and not chest mass extending into the abdomen? So you need to see whether the lower borders are converging towards the abdomen or lower borders are diverging towards the abdomen. Okay, so like in this case, the lower border of the mass is converging towards the abdomen. That means the epicenter of the mass is in the chest, most likely in the posterior mediastinum. Okay, in this case, the lower border of the mass is diverging towards the mediastinum. That means the epicenter of the mass is in the abdomen, most likely in the retroperitoneum and not in the chest. This is a retroperitoneal mass extending into the abdomen. Okay. Now coming to Hilem-Overlay sign. Hilem-Overlay sign we have already discussed. So basically Hilem-Overlay sign will help you to differentiate hilar masses from anterior or posterior mediastinal masses. Okay. So this is the mediastinal mass, and through the mediastinal mass opacity, you can see the vessels, pulmonary vessels. So this is hilum overlay. Okay. So now you can tell the mass is either situated into the anterior mediastinum or a posterior mediastinum, but not into the middle mediastinum, because you can see the pulmonary vessels through the opacity. Okay. When a mass arises from the hilum, the pulmonary vessels are in contact with the mass is obliterated. So if the mass is arising from the hilum, then you will not be able to see pulmonary vessels clearly. So then you can label that the mass is seen arising from the middle mediastinum when the pulmonary vessels are not separately visualized. But if you can spot pulmonary vessel traversing through the opacity, that means the mass is not arising from the middle mediastinum. It is either arising from the anterior or posterior mediastinum. Okay. So the ability to see the edges of the vessel through the mass implies that the mass is not contacting the hilum, and therefore it is either anterior or posterior to it. Understood? Now coming to the hilum convergence sign. So what is hilum convergence sign? So convergence sign will help you to distinguish bulky hilum due to pulmonary artery dilatation or from a mass or nodal enlargement. Okay. So many a times you see bulky hilum, but you will not be able to exactly tell whether it is a vascular origin likely arising from pulmonary artery, or it is a mass or nodal origin. So the hilum convergence sign will help you in such cases in order to differentiate whether it is whether the opacity is because of the pulmonary artery opacity or because of the mediastinal mass slash nodal opacity. So if the pulmonary vessels converge towards the opacity, then it is due to pulmonary artery origin. Like in this case, this is a case of Eisenmingerization. Here, see the dilated pulmonary arteries and the bulky hilum is here on both the sides. So if you see the pulmonary arteries are seen converging towards the bulky hilum, then that means the opacity is of pulmonary artery origin, like in this case. If the pulmonary vessels are converging towards the heart, that is seen through the opacity, then it is due to hilar or mediastinal mass. Understood? If the pulmonary vessels are seen converging towards the heart through the opacity, that means the enlargement, the bulky hilum is due to hilar lymph nodes or some mediastinal mass. This is the last sign we are going to discuss. So this is a incomplete border sign. Incomplete border sign suggests that the mass is of extrapulmonary nature. Okay. So what is incomplete border sign? Incomplete border sign tells you that there are two borders. Okay. So one of the border is very well seen, very well defined because of the nature of the X-rays and the adjacent lung tissue. So there is significant difference in density of these two structures. That is the reason you are going to identify the well-defined nature of the lesion. The outer border, it is not very well visualized. That is the reason it is called as incomplete border sign here, because the X-rays are traversing at this location tangentially. That is the reason you are not able to clearly identify where is the boundary of this lesion. So an extrapulmonary mass will often have an inner well-defined border and an ill-defined outer margin. This can be attributed to the inner margin being tangential to the X-ray beam and having a good inherent contrast with the adjacent lung parenchyma. On the other hand, the outer margin is en-face or partially en-face with the X-ray beams and merged with the pleural or the chest wall. Thus, the border is obscured. So that is the reason extrapulmonary masses will show incomplete border sign. Now, this is very straightforward. Even you can tell this is even the first year resident can tell that this is a extrapulmonary nature, because this is forming obtuse angle with the lung parenchyma. But sometimes such lesions will not be situated at the border of the chest wall, and you will have such kind of appearance of the incomplete border sign, extrapulmonary nature of the lesion. So here, as you can see, the upper border is not very well visualized. The lower border is well visualized on this radiograph. So this is a incomplete border sign, and this is the chest CT of the same patient, and here you can see there is this lesion, and this is extrapulmonary in nature. So sometimes the lesions are not seen in profile view. Lesions are seen sometimes in end face view, and in such lesions you will be able to identify which border of the lesion is well defined, which border of the lesion is ill defined, so that you can apply incomplete border sign over there. So that is the end of session, guys. I hope you like this session. uh, if you want to see many more such sessions, then I am uploading such sessions on FRCR Shorts YouTube channel. This session I will also uploading on FRCR Shorts YouTube channel. If you want any more sessions to be discussed, any particular topic, then you can put it in the comment section and let me know. Thank you, guys.